All right, so we're going to go over palpation for the foot and ankle region. So the first thing we're going to palpate is the fibular head. So again, that fibula runs up and down the lateral aspect of the leg there. And so that fibular head is that bony prominence right there on the lateral aspect. You can either find the joint line and come down from there, or you can go to that lateral malleolus, palpate that fibula all the way up, and end up on that fibular head right there. The next one is the tibial crest. So that is that anterior aspect of the tibia right here. You'll feel that bony ridge coming all the way down the anterior aspect of the shin there. Next is the anterior compartment musculature. So if you go from that tibial crest right there and you go laterally from there, the large muscles that you'll palpate right there, those are your anterior compartment musculature. So palpate those. And then again, as we're palpating, we're not identifying, right? So we are identifying, but we don't want to just be identifying. So you're not going to say, okay, I'm palpating the anterior compartment musculature. You want to actually feel the quality of that tissue, see if that's tender for your patient, see what the tissue feels like, if there's any swelling in that tissue, any increased pressure. So make sure when you're palpating, you're actually feeling what that tissue feels like. Next is the lateral compartment musculature. So again, if you go, you find that fibular head, you know the fibula is right there, your lateral compartment musculature is right there. So you're gonna again palpate the length of that tissue, and those tendons run on that posterior aspect of the lateral malleolus right there, so you can palpate up from there. And again, if I have my patient evert, those muscles are gonna pop up, and so I can palpate along there as well, because those muscles are responsible for primarily eversion. All right, next is the gastroc soleus muscles. So have your patient flip into prone here, and then you can see those muscles right there. So again, gastroc is that wider, meatier part of the calf right there, and then soleus is deep to that and runs down, and they both feed into that Achilles tendon right there. So the next thing we'll palpate is the Achilles tendon. So again, that runs from that posterior aspect of the calcaneus up into that gastroc soleus musculature, and so you can palpate along that. And again, I'm not just pointing to it, I'm actually palpating the quality of that tissue, seeing if there's any stiffness, any significant swelling. I can kind of wiggle it back and forth, get a good assessment of the quality of the movement of that tissue there. Next, I can palpate the calcaneus, and so again, that's my big heel bone right there, so I can kind of do that calcaneal compression from either side. I can palpate the posterior aspect of it where that Achilles tendon inserts. I can palpate that plantar aspect of it as well. So that's your calcaneus right there. And then if my patient can flip back into supine. All right, so next we will palpate the lateral ligaments of the ankle. So again, there are 3 of those. They kind of run just like that. So we have the ATFL, which is going to come off the anterior aspect of that distal fibula right there. And so I'm going to palpate that coming forward, and that's going to go to the talus. So I'm right over that ATFL right there. Then I have the CFL, which is going to go from my calcaneus to my fibula, or my distal fibula right there. So that is going to go right here. So I can palpate that CFL right there, going straight down to that calcaneus. And then my PTFL, so again, the posterior talofibular ligament, that is going to go from this posterior aspect of the distal fibula going back towards the talus there. So I can palpate back just like that. And that's your lateral ligaments of the ankle there. Next is the medial malleolus, right? So, well, we have the lateral malleolus, which we were just talking about. So again, that distal aspect of the fibula there. And then the medial malleolus is on the medial side, that distal aspect of the tibia. So you can palpate that through there. And again, we want to palpate the anterior aspect of that, coming all the way around, feeling if there's any tenderness within that area, any irritation. Then we can palpate the deltoid ligament. So again, that's comprised of 4 ligaments on the medial aspect of the ankle right here. You don't need to know the individual names of each of those ligaments. But again, if you come off this distal aspect of the, or this lower aspect of the distal tibia, and then palpate posteriorly and then anteriorly you're over the deltoid ligament there. So you can assess if there's any irritation, any disruption of that tissue. And then next we have the cuboid. And so in order to find the cuboid, I can have my patient relax a little bit. So if I come and I find the base of the 5th metatarsal, so again, I'm coming along that 5th metatarsal, I'm right over the base right there. And then if I come straight back from there, I'm gonna be over my cuboid right there. So next we'll palpate the navicular, which is on that medial aspect of the foot right here. And so again, it's that bony, kind of most bony prominence on that medial aspect. In some of your patients, you'll see it in more than in others. You can kind of see it jut out right there. And so one thing you can do is go from that medial malleolus, go distally, and then that first bony prominence that you hit is going to be your navicular. Another thing you can do is come along that first metatarsal and then come back, and then where you feel that dip off into soft tissue, the thing you dipped off of right there is your navicular, so that can help you find it. You can also come kind of right from that mid part of the arch and come up and palpate the navicular that way. We have the cuneiforms, and so those lie distal to the navicular. So again, if you found that navicular, that comes across just like that. And so I know distal to that, I'm going to have my cuneiforms. So again, you have your first, second, and third cuneiform. Another thing you can do is palpate the metatarsals coming back, and then where you feel that dip in the metatarsal, and it comes onto a new bone right there, that's going to be your first cuneiform if you're coming off of that first metatarsal. And you can come over and palpate your second and then your third as well. And then again, if you kept going along that line, where you're going to hit is your cuboid, because that lines up with that row as well. Then again, we just talked about the metatarsals, but those run, again, those are those long bones that run along here, so you can palpate each of those. And again, we're not identifying or just identifying, we're palpating, right? So I'm trying to get an assessment of whether there's irritation of that tissue, whether the bone is tender, there might be a stress fracture or an injury to that area. So I'm going to palpate for the quality of that. And then the last thing we'll palpate is the plantar fascia. So my patient can go into prone. So next we'll palpate the plantar fascia. And so again, that originates on that medial plantar aspect of the calcaneus here, and then runs down to your digits. And so you can find that by putting the ankle into dorsiflexion and extending that great toe, and you'll see and feel that plantar fascia get really taut right along that plantar aspect of the foot there. And you can have your patient relax. And then again, palpate from that medial plantar aspect of the calcaneus down along that plantar fascia and going out to the digits there. Good. You okay with that? Mm-hmm. Awesome. All right, so next we'll go over range of motion measurements for the ankle. And so when we are measuring dorsiflexion and plantar flexion, you're going to line your goniometer. Your axis is going to be on that lateral malleolus. Your stationary arm will be lined up with the fibular head, so going up the lateral aspect of the leg there. And then your moving arm is going to be parallel to the 5th metatarsal. So you want to make sure you have that lined up parallel to the 5th. So again, you should have straight lines going next to each other, running in a parallel course. And then you'll instruct your patient to dorsiflex. Yep, so then again, I'm going to move that so it's parallel. You get my measurement for dorsiflexion there. Come back to neutral. Good, and then have my patient go into plantar flexion. Good. Again, I'm moving this so that it is parallel to. Good. Making sure my stationary arm is still lined up with the fibular head there, making sure this is parallel to the 5th, and my axis is still on that lateral malleolus, and then getting my measurement for plantar flexion there. So again, the norm for plantar flexion range of motion is 50 degrees, and for dorsiflexion range of motion is 20 degrees. So next we'll go over inversion and eversion. So I'm going to line this up with my stationary arm in line with my tibial crest. My axis is going to be in between my malleoli, and then my moving arm is going to be lined up with my second metatarsal. And so then I will have my patient go into inversion. Good, and then move that so it's lined up with my second metatarsal, making sure this is still in line with my tibial crest right there. Good. So again, normal for inversion range of motion is going to be 40 degrees. Then I'll have my patient come back to neutral. Make sure everything's still lined up. So again, stationary arm lined up with my tibial crest, axis of motion lined up between my malleoli, and then my moving arm is lined up with my second metatarsal. Then I'll have the patient go into eversion. Good, make sure everything's still lined up. And again, normal range of motion for eversion is 30 degrees, and relax. So for manual muscle testing for plantar flexion, again, for testing grades 3 to 5, you're gonna have your patient standing. You're gonna have them shift all their weight. Again, they can use the table for balance. So again, just fingertips on the table there. They shouldn't be putting a lot of their weight on it. Yeah, exactly. And so then you'll have them shift their weight to whatever extremity you're testing, and then ask them to perform controlled heel raises. So coming up on your toes, coming back down. And then we're seeing how many the patient is able to perform. So again, if they perform 1 to 4, that is going to be a grade 3. If they perform 5 to 9, that will be a grade 4. And if they're able to complete 10 repetitions, then that is going to be a grade 5 or normal.
That's 10.
Normal. So for dorsiflexion, manual muscle testing, again, you'll have your patient go through the range of motion. So bring your toes up towards my hand. Good. Relax down halfway. Again, I'm stabilizing posteriorly and proximally to the ankle. And then I'm going to place my hand right here on the dorsal aspect of the foot, and then have the patient hold there, meet my resistance. 3, 4, 5, and relax. So they're able to maintain that. So they would have a 5 out of 5 on that. And then for eversion, I'm going to have, again, my patient bring their foot towards my hand. I am going to stabilize proximally to the ankle on that medial aspect, and then I'm going to have them come back halfway and then meet my resistance. 3, 4, 5, and relax. So again, that would be a 5 out of 5. And then for inversion, again, my stabilizing hand is going to come to the lateral aspect of the leg, and then have my patient come into inversion, come halfway out of that. Good, hold right there. 3, 4, 5, and relax. All right, so for physiologic joint mobs for the ankle, you're gonna have your patient in the prone position and then have them scoot towards you, which my patient's already done. And then you're gonna bring their leg, their knee into that flex to 90-degree position there. So for dorsiflexion mobilization, this hand is going to grab that distal aspect of the plantar aspect of the foot there, and then this hand will be on that calcaneus. And so then what I'm going to do is facilitate that motion into dorsiflexion, feeling for that resistance. So as we're mobilizing into this, again, so grades 1 and 2 would be addressing pain out of resistance. If I'm working on grades 3 and 4, so again, I'm going in and finding that resistance. Grade 3 is going to be that large amplitude, working into that resistance. And then grade 4 would be a small amplitude, working into that resistance there. Okay, so then to work into plantar flexion, physiologic mobilizations, this hand is going to go on that dorsal aspect of the foot there, and then this hand will go on that plantar posterior aspect of the calcaneus. And then again, I'm just working into that plantar flexion range of motion. So again, you won't hit resistance as quickly with this as you likely will with dorsiflexion, because remember, there's a lot more range of motion with plantar flexion than with dorsiflexion. So again, as we're working into it, I start to feel that resistance right there. So I can do grade 3, which is that large amplitude, or I can do grade 4, which is working in that small amplitude into that resistance. All right, so then to work into inversion and eversion for grades 2 and 3, our positioning is going to be the same. And so what we're going to do is grab that plantar aspect of the foot. Again, I would lower my table We're going to hold that, and again, this motion is focusing on the calcaneus because inversion eversion occurs at that subtalar joint, which is that calcaneus moving on the talus there in this position. And so we're focusing that force on the calcaneus. So again, I can go into inversion or go into eversion in this position. I can kind of rock back and forth between the two, but again, go into, feel that resistance, and then again, grade 2 if we're working into pain, but grade 3 if we're working into that resistance there. I can do that large amplitude, same thing going into eversion. And then if I want to do that grade 4 for inversion, I'm going to switch my hands and come along this lateral aspect of the calcaneus here, go all the way into that resistance, and then do my small amplitude right there. So going to accessory joint mobilizations, we're going to first do the talocrural posterior to anterior, so PA glides. So again, I'm gonna bring my patient into a neutral position right here. So you can use a towel to kind of hold that ankle in that position. Otherwise your patient's gonna be falling into more of that plantar flex position in this, as they're laying prone here. So I'm gonna line my patient up in that neutral position. I'm gonna take that first web space of my hand here. This hand can actually have you scoot up just a tiny bit. So I'm going to take this hand, my proximal hand is going to help stabilize, and so what I can do is kind of position that between the table and my patient's leg so that I have good control there, but then I'm not having to do all the work because the table is kind of supporting it. And then again, I'm going to line up that first web space right over that posterior aspect of the calcaneus right there. And then I'm going to drop my weight into that and perform a posterior to anterior glide. So again, I can feel for that. I'm going into resistance. Once I hit the resistance, I can do a grade 3, which is that large amplitude, or I can do a grade 4, which is that smaller amplitude. And again, ideally, for your own body mechanics, this table would be a little bit lower so that I can kind of lock my arm out and then just drop my weight into it. Okay, so then for talocrural AP glide, so anterior to posterior, again, I can use this to help stabilize here. Can you scoot down just a tiny bit? Perfect. So again, using that to stabilize my patient, to keep their ankle in a relatively neutral position. Again, that proximal hand is going to go along the shin or along the leg to help stabilize that area. And then my first web space is going to line up with that talus. And then same thing, I'm going to take up that slack with this as well, so you can have you have the tendons running through there, you have some soft tissue running through there, so you want to kind of move those out of the way a little bit and get that web space lined up with the bone. And then just like with the PA glides, I'm going to drop my weight into that, feel that resistance being taken up, and then I can perform my mobilizations there. Either a grade 3 with a large amplitude or a grade 4 with a small amplitude. Okay, so then for distal tib fib, AP and PA glide, so we'll start with PA. So your patient is in a sideline position. This lower leg is flexed to help kind of stabilize the upper leg there. And then for this one, there's two methods you can use for it. So one is to take this aspect of the hand, the thenar eminence, and line that up with that posterior aspect of the distal fibula or that lateral malleolus, and then take the other hand and kind of interlock your fingers and place it over, and then use that as a driving force. Again, we want to get lined up so that the force we're directing is going straight forward, and we're not pushing down into that joint there. So again, lining that thenar eminence up and then providing that pressure forward. Again, you're going to feel that resistance pretty quickly because there's not a ton of motion at this joint right here. Another method you can use is to use your thumbs. Again, you're going to line it up on that posterior aspect of the lateral malleolus, and you want to overlap them just like that. And then one is just stabilizing right there, and the other one is providing that force. And again, providing that posterior to anterior directed force on that distal lateral malleolus, which is going to help facilitate plantar flexion range of motion. Okay, so then to perform anterior to posterior distal tib fib glide, so distal tib fib AP, patients in the same positioning as the PA glides, but our force direction is going to be different, obviously. So again, I can come and take that heel of my hand or that thenar eminence, line it up with that anterior aspect of the distal fibula, and my other hand is going to overlap. And then again, I'm getting at a level where that force is going to be directed straight back, not down into the leg. So I'm going to line up and then apply that AP force. Again, depending on the size of your hands, depending on the control you have, depending on the size of your patient's distal fibula, it may be more comfortable to use your thumbs instead. So figure out what feels best for you. But then again, I can come line up on that anterior aspect and then apply that anterior to posterior directed force at the distal fibula, which again that anterior to posterior force is going to facilitate dorsiflexion range of motion.